to the MRCPology channel for a quick review and understanding of the topic. Imagine a patient who says, "Doctor, every time I write for a few minutes, my hand starts twisting and I grip the pen too tightly." Or another patient whose neck repeatedly pulls to one side, especially when they are tired, stressed, or trying to concentrate. These are typical clinical scenarios where focal dystonia should come to mind. Focal dystonia means involuntary, sustained, or intermittent muscle contractions affecting one body region. These contractions produce abnormal postures, repetitive twisting movements, or both. The important word here is focal because the dystonia is limited to one anatomical region, such as the hand, neck, eyelids, jaw, tongue, or voice muscles. Let's simplify the mechanism. Normal movement depends on two things happening at the same time. The correct muscles must be activated, and the unwanted muscles must be inhibited. In focal dystonia, there is dysfunction in the basal ganglia cortical network. This causes impaired inhibition and abnormal sensorimotor plasticity. So the flow is, basal ganglia cortical network dysfunction leads to reduced motor inhibition and abnormal plasticity. Reduced inhibition causes overflow activation of muscles that should remain quiet. Abnormal plasticity causes motor maps to become poorly separated. The final result is excessive co-contraction of agonist and antagonist muscles, producing a patterned dystonic posture or twisting movement. Clinically, this means muscles that should work separately start contracting together. For example, during writing, instead of smooth finger and wrist control, the patient develops excessive gripping, abnormal wrist posture, and loss of fine motor precision. This is writer's cramp, which is a classic task-specific focal dystonia. Now pause here, because plasticity is an important concept. Plasticity means the nervous system's ability to change or rewire its connections and responses based on use, learning, and sensory input. Normally, repeated movement allows the brain to fine-tune motor circuits. The more we practice a movement, the more accurate and efficient it becomes. But in dystonia, this process becomes excessive or abnormal. Motor maps become poorly separated, so muscles that should activate independently begin activating together. That is why focal dystonia can appear early during highly skilled repeated tasks, such as writing or playing a musical instrument. In MRCP, the clue is task specificity. A hand that twists only during writing suggests writer's cramp. Abnormal finger posturing only while playing an instrument suggests musician's dystonia. Now let's move to the clinical patterns. Cervical dystonia affects the neck muscles. The neck may twist, tilt, flex, or extend depending on which muscles are overactive. Some patients also have a tremor-like movement, but the key mechanism is dystonic contraction rather than a simple essential tremor. Blepharospasm affects the muscles around the eyes. Patients develop involuntary eye closure, which may interfere with reading, walking, or driving. The clue is repeated forced eyelid closure, not just ordinary blinking. Oromandibular dystonia involves the jaw and tongue. It may cause jaw opening, jaw closing, jaw deviation, tongue protrusion, or difficulty with chewing and speech. Laryngeal dystonia affects the voice and can produce strained, breathy, or interrupted speech. A very useful clinical clue is that dystonia often worsens with action, stress, and fatigue. It may improve with a sensory trick, also called a geste antagonist. For example, a patient with cervical dystonia may touch the chin or side of the face and temporarily reduce the abnormal neck posture. This is a classic exam point. Diagnosis is mainly clinical. You recognize the pattern, involuntary muscle contraction, abnormal posture, task specificity, action worsening, and sometimes improvement with a sensory trick. But do not stop there if the presentation is atypical. In MRCP, you must think about secondary causes. Drug-induced dystonia can occur with dopamine-blocking drugs, such as antipsychotics or antiemetics. Wilson disease is important in younger patients, especially if there are liver, psychiatric, or other neurological features. Stroke, structural basal ganglia lesions, and neurodegenerative disease should also be considered if the onset is sudden, progressive, or associated with other neurological signs. Do not confuse dystonia with tremor, chorea, weakness, or spasticity. Dystonia is usually patterned and posture-producing. Tremor is rhythmic. Chorea is random and flowing. Spasticity is velocity-dependent increased tone with upper motor neuron signs. Now let's talk about treatment. First-line treatment for most focal dystonias is botulinum toxin injection into the overactive muscles. The mechanism is high yield. Botulinum toxin blocks presynaptic acetylcholine release at the neuromuscular junction. This weakens the overactive muscle and reduces the dystonic posture or movement. The aim is not complete paralysis. The aim is to reduce excessive contraction enough to improve posture, pain, function, and quality of life. Adjuncts include physiotherapy, especially for posture, stretching, motor retraining, and functional adaptation. Oral medications such as anticholinergics, baclofen, or benzodiazepines may be used in selected cases, although side effects often limit their use. For severe refractory cases, deep brain stimulation can be considered, usually targeting the globus pallidus internus, or GPI. The MRCP trap is this. Typical focal dystonia is a clinical diagnosis. Imaging and blood tests are not needed to prove every case, but they are important when the presentation suggests a secondary cause. So if you remember one thing, remember this. Focal dystonia is focal, patterned, and posture-producing. It reflects impaired inhibition and abnormal sensorimotor plasticity in basal ganglia cortical circuits. It may be task-specific, may improve with a sensory trick, and is usually treated first line with botulinum toxin. A quick recall question. A patient develops abnormal hand posturing only when writing. What is the diagnosis? Writer's cramp, a task-specific focal dystonia. Second question, what is the first-line treatment for most focal dystonias? Botulinum toxin injection into the overactive muscles. Focal dystonia is an involuntary patterned contraction affecting one body region. Look for task specificity, sensory tricks, and action worsening. Exclude secondary causes when atypical. Treat most cases with botulinum toxin and reserve GPI deep brain stimulation for severe refractory disease. Do subscribe to the channel for further videos.